you very shortly. If this is your first time, welcome. There's a monthly CPD POCUS meeting for anyone who's interested. Obviously, a big emphasis on paediatrics and PEM. It's a form of supervision for those who've got questions or would like to share some of their own experiences. So going forward, I'm very, very happy for people to get involved, or if anyone would like to present a topic, that would be excellent. So please ask as many questions as you feel able to do during it. We'll put our videos on the YouTube channel, so it's the recorded talks or the longer ones, and then we've got some short talks ranging from a couple of minutes to sort of 6 or 7 minutes, just going over some useful signs and findings. So I don't think I'm going to be rivaling Jake Paul or anyone like that anytime soon in terms of views and followers, but hopefully there's some content on there you guys will find useful. And then just a really quick one, we've got our own POCUS course.
Maybe you're still on your title slide, sorry.
Right, thanks. Right, so why is that? Right, I'm going to just go back to the other mode. Thanks for telling me, Nigel. I'm just going to stop sharing through that, and I'll share through the PowerPoint Live. It's much easier for me. The only thing was just 1 or 2 little bits that I can just talk you through. Right, can everyone see that moving?
Yeah, that's fine.
Yeah, and again, moving. 1 sec. Now.
Yep.
Right, okie dokie. So yeah, so the videos are up there. Okay. Can anyone? You can't see anything.
I can see it moving now.
Okay, for those who can't, I think it did happen with the odd person. I don't know why it happens, but they were just log back in and it worked fine. So hopefully people can. Yeah, can people see?
Yep.
Grand.
Yep, can see.
Spot on. So technical hitches out the way with. Grand. So sorry, just need to do the arrows. So yeah, so we've got our own course, date advertised in March, which is a PEM specific stream, and places really limited. They've largely filled, but if anyone's interested in attending, that's in March, and can chat to you about that in the future if you send me an email. This is the link, and this is our website. Okie dokie. So I thought I'd do a mixture of cases really. And the first case I saw was a 6-year-old boy. I was working in the ED, and a colleague had reviewed him, one of the other consultants, and it was a 6-year-old boy who'd had some mixed symptoms, some back pain, some temperature, some loose stool, and attended our department looking fairly well, actually. However, it was really unclear what had been going on. Based on the person who'd seen them, they weren't particularly convinced that there was a simple gastroenteritis causing the tummy pain, the loose stool. They were complaining of back pain. So for whatever reason, a set of bloods got undertaken, and then the handover was handed on to me. I hadn't met the child, and this is what I got. So I'm not a big blood sort of person, for anyone who knows me. You know, when helping to get us closer to a diagnosis, they'll clearly fulfill an important role in some remits, but I really didn't know how to interpret these bloods with this very well-looking child with normal observations. So I guess the question was, should I undertake a scan? Should I extend my clinical examination by scanning? And I did. And the first place I started was the lungs. So I had a look and had a look in the right side of the lung, right lung, and it was all nice and clear. And then lo and behold, on the left side, when placing the curvilinear probe and then the high frequency probe at the lower left posterior and lateral area, I didn't see what I would expect in the lung. In fact, I saw this almost solid organ looking thing, an additional liver or spleen in this case, and this was frankly hepatized lung, very, very densely hepatized. For those who are beginners, we can see this sort of dynamic, well, partially dynamic air bronchograms as these bright lines above the diaphragm. And yeah, I saw a very frankly consolidated lung. So this is just a very early entry-level case for the talk today to get you thinking about, you know, which of these things were more helpful for me. You know, a extremely concerning CRP in a very, very well-looking child, afebrile currently with normal observations. So today's talk's all about pearls and pitfalls and POCUS. So some of them will be pitfalls about being aware, but largely it's going to be about hopefully pearls, little pearls of wisdom that you can take with you when you're in the department. And I've always thought that doing a scan does no harm. it's part of our clinical exam. We extend what we're sort of thinking and feeling pre-scan, and using POCUS to visually validate what we think might be going on. Now, obviously, lungs would have been a reasonable place where I would always start in a child like this, bearing in mind, obviously, they didn't have cough or, in fact, temperatures and look very well. But it's always a reasonable thing to do in a child, particularly during winter. And I was really struck by what I'd found. So I think my message here is that until we've had a thorough look, it's hard for us to say that there's a fever without an obvious source. And this was an original paper by Daniel Lichtenstein, who was one of the initial lung sort of founding fathers of POCUS lung around about 15 years ago. And it talks in this paper about kind of, particularly with work in children on ITU and more poorly children, about undertaking a further, much wider sonographic assessment. Looking at skin and joints, looking particularly in lungs, I guess, is a really big one. So POCUS will never do any harm, all right, used in the right hands. Bloods and X-rays obviously can. So, and yeah, we eventually got his X-ray, and we can see there is a bit of dense, slightly pacification on the left relative to the right, I suppose, but certainly not as much as what we would have expected with this frank hepatization. Child did really, really well. Okay, right, into the more meaty stuff. So I saw a 15-year-old girl who'd had some abdominal pain, right lower sided. She'd had some non-bilious, non-bloody vomits. There was no possibility of her being pregnant. And when I examined it, she was really tender suprapubically, but not too much else to find particularly. Didn't behave in any way peritonitic. Her urine was fairly unremarkable. So I did a scan. Anything in a quote or anything printed out directly from the notes is exactly how it happened on the day, so how it was written by me. I'm not trying to kind of spin anything. So this is what I'd scanned. So I placed the curvilinear probe up in the right upper quadrant, looking initially for free fluid as a good starting place for my scan. And then I had a look down lower around the source of pain. So again, curvilinear probe, and I was struck by something really unusual, a very, very large anechoic, hypoechoic structure, which was either a large bladder or an additional fluid-filled area. Further scans, as you can see, this is the depth of around about 12 centimeters, occupying most of my field. We've got this brightness behind it, which is this posterior acoustic enhancement, implying that this is fluid-filled and the ultrasound echoes are coming through more readily. So yeah, this was really unusual, and I had heard about this thing called the double bladder sign, and I think this is what I was seeing. So, two bladders, or at least, yeah, at this point, had I even seen the bladder? Possibly not, but something that could have been a bladder. So my other view makes it a little bit clearer that we do eventually see a bladder when we're aiming very, very inferiorly, just above the kind of pubic symphysis. And yeah, the double bladder really is typically talking about concerns about usually a large ovarian cyst. And in particular, some studies have begun to show that the appearances of this are fairly specific for ovarian torsion. So based on the size of the cyst, taking on a bladder-like appearance, and the abnormal location of the ovary, there's significant concern that this can lead to torsion, obviously as a result of a cyst leading to ovarian torsion. And there's some evidence that this can be a really, really useful early sign, predating the kind of more obvious sonographic signs for torsion of the ovary. So I think when you're doing your scans, just be really careful that if you see something large that's maybe larger than you expect in a child, that you are in fact just seeing a normal bladder and you're not seeing something else. And of course, if you see two large fluid-filled structures, I think it's something to be really, really concerned about. There is a simple formula for measuring fluid within the bladder. So if you're ever concerned that what you're seeing might be overly large, there's a simple way of doing that, and that's just two measurements in the transverse plane, effectively height, sort of width and height. And then again, when we rotate into long section and get the sagittal plane of the bladder, you do the height, so the biggest measurement is the height, and then times that by 0.6. So if you were to get incredibly high numbers based on the size of this very small child in this very, very large area, you might check that and think, okay, this doesn't seem right. That's more than 1.5 litres in the bladder. And the reason I say that is because this child went for a formal scan, because obviously I was a little bit concerned about what I was seeing and knew surgical or gynae specialties were going to be involved. Remember, my POCUS is never going to be precluding the use of a more formal radius in certain cases, and it might be maybe 1 in 15 of the scans, or it's maybe a bit high, maybe 1 in 20 of the scans we do require further radiological assessment. And when they scanned it, they found that there was over 1.2 litres in this large right ovarian cyst, and in fact, a confirmed double bladder sign with a normal bladder below it and a large ovarian cyst. So that the gynae team got involved and performed a cystectomy and drained, as I say, a large amount of fluid. So I thought that was just a really interesting one, again, for a very well-looking child who I didn't expect to find something so unusual. Any questions about that case, or in fact about the first case?
There was a question about how comfortable the patient was during examination with the probe.
Yeah, so fairly comfortable actually, and ultimately not peritonitic, not behaving like some of the surgical patients who I might expect, to really, really guard me when I'm beginning to take particularly an appendicitis scan or a right lower quadrant scan. So no, just not even a palpable mass, to be honest, but just, we use POCUS to rule out other things that we possibly can't get just from examination alone. And with the two things, normally we're saying everything's fine, you're absolutely fine, you can be discharged. But in this case, not a lot of clues really until I found this really unusual thing, which is why I guess I've included it as a case. Hopefully that's clear, Reggie. So my pitfall, hopefully you guys get the film reference there, is beware of the false bladder. Okay, moving on. So changing tact a little bit here. Nice scan, but something I don't get to do that often, unfortunately. 15-year-old boy was coming out of school and he tripped, landed on his right shoulder. He looked in a lot of pain. His arm was held as described, and he was neurovascularly intact. So I was hoping and had a suspicion, not for him, but just to keep up particular skills, that this might have been a relatively rare PED presentation of a shoulder dislocation. You adult guys on the call get to see this a lot. I think I miss it. We probably get less than probably about 1 a month, 1 to 2 a month max. So I just had some training during my postgraduate stuff on doing shoulder POCUS, and I did with him. So I tend to take this posterior approach using a high frequency probe. So we're scanning here in this case, the probe mark is superior, so superior and inferior. But our near field here is posterior and our far field is anterior. And this is what I saw. Sorry, that's not a cine loop, that's just a picture. Tried to click it. So I can see the sort of tissue of the glenoid, the socket of the shoulder with the musculature here posteriorly in front of it. But I can see there's no congruency between the humeral head and the glenoid. So this is what a dislocation looks like. Here's some sonoanatomy to show you. So basically we're just looking for the hypoechoic lines of the humeral head and the scapula, and the rest of the tissues of the glenoid congruent there. But when we get typically an anterior dislocation, you see the scapula and everything else, but then all you'll see in the middle is either anechoic black fluid, or you might not really make out much at all, but you'll certainly see the bony humeral head displaced quite a few centimeters anterior to that. Does everybody make sense? Does that make sense to everybody in terms of the view and the positioning? So what was really nice about this case was, before all of that, no, we did get that in the end. I'd got the x-ray pre, but what was really nice was a couple of things. I got him started on cement knock straight away after his x-ray, and utilised this thing called the Oxford chair for a reduction. This has nothing to do with PEM, with POCUS, sorry, but if anyone's heard of this or used this, it is excellent, incredibly excellent. And this reduction took me about 4 seconds to do, with his arm over the chair. And I'm going to show you the chair in a second. And I think we'd saved a lot of time using POCUS. We were able to get him x-rayed briefly. I'm going to talk to you a bit about that. And then here we go. We've got our glenoid and our fossa, and then we've got our humeral head sitting kind of right next to it within 0.5 centimeter, as opposed to down here where it was before. So my pearl here would be, POCUS can definitely reduce the time taken for reduction. POCUS can and should definitely be used to confirm reduction. there are some emerging bits of evidence about whether or not there's a suitability just for POCUS in certain pediatric patients. Now, we know these bony lesions that they have, the kind of Hill-Sachs labral lesions and the bony Bankart lesions that adults get are a lot less common in pediatrics. I'm not an expert in shoulder dislocation because I've just said that we don't see it massively often, certainly not compared with when I used to do adult ED back in 2009. But I think what I'm trying to do with this PEM POCUS UK and these sessions and getting people interested in using POCUS is we would be the people who would undertake service provisions and studies and evaluations of our work, looking at whether or not it is safe to just undertake POCUS instead of x-rays or before pre-reduction x-rays or do away with post-reduction x-rays to reduce radiation and all other things like that. I'm not saying that at the moment that's where we are. I'm just saying that we live in a world where ultrasound is now very much at the forefront. It's really, with the correct training and once you've mastered your skills and you feel very comfortable with it, we can begin to consider the need for reduced things like chest x-rays and x-rays for buccal fractures of simple distal radius fractures. That's kind of the leap that I'm beginning to take in my own department. Haven't been doing it for a while. And I think that that's where, as a group, we could be in 5 years' time. And I always talk to my colleagues about, well, where will we be in 5 years' time? And I think it's absolutely safe that in certain orthopedic presentations that we can be substituting POCUS for x-rays. And then this is just the Oxford chair. For anyone who hasn't seen it, you basically hang your arm over and slight bit of external rotation, and that's it. It's fantastic. Any questions about that? Any queries? Anyone want to ask anything? Can I repeat the probe position? Yeah, sure. So there's different ways to do this. One is just to have the probe, high frequency probe here laterally and just scan up from the humerus there right up to where you begin to meet bone of the scapula. And that's really simple. You just see it in a linear fashion. But the one I was taught was just this, whereby we see the humeral head anterior because the humeral head's going to be here relative to the glenoid here. So we see this big gap when really what it should look like is that, and we see that. Does that all make sense? Hopefully so. Granted, someone else works, just reading the chat to keep everyone in the loop. Jamie works in adults, so it's moving fast. Too fast for me to keep up with this, but yeah, someone seems to agree. So I just think we should be starting to ask these questions, and I'm possibly a little bit of a disruptor, maybe at my own place, but I've got a lovely relationship with orthopedics, in particular, a few consultants. But I'm just beginning to ask questions about, well, do we need to do things the way we've always done them, or can we start to think about? Of course, you need a service evaluation or some output, research or otherwise, to begin to verify doing that, and of course that takes time. Have I had to use curvilinear and obese? Yeah, the views in curvilinear are okay as well. It's just obviously it would probably be more suitable, I guess, for a bigger adult. I've not really had this particular opportunity in a large obese adult or a large obese child, but yeah, as long as you master what you're seeing, I think either are appropriate. Okay, so this was a 15-year-old who I saw one afternoon. Thank you, Khaled. Yeah, who literally looked like this when they came in. They were hanging, it was that last Christmas, I think, or the one before, they were hanging Christmas decorations, and then this large piece of glass sticking out the hand. So give him some analgesia, we'll get him cleaned up, remove the pieces of glass and externally, and then I had a scan around through the palmar surface to look for foreign body. So we've got this nice internal guideline we wrote about selected reductions of superficial soft tissues. You can see me here with my probe in my left hand and my forceps in the hand, beginning to push on this large linear hyperechoic piece of material, which was a piece of glass at about roughly 0.5 centimeter. I typically mark out the sort of boundaries of where I think the soft tissue is, either with pen or just keeping a really good note, usually with a skin marker, but sometimes just knowing its length roughly in one plane, and then thinking about whether it's going to be suitable for removal. So this was a big lad. He was very happy for me to go ahead. So I did. So I removed this piece of glass straight away. Well, not straight away, but got it. And then I was talking to his parents, getting him cleaned up, chlorhexidine, just about to suture him up after a bit of a further washout. And his parent asked me, what would it be like? What would it look like if there was any more glass in and around? So I'd shown it. I think she might have. I don't think she was looking at the screen when I demonstrated this to her. She then was asking me what a foreign body would look like, basically. And I was showing her the screen this time. She was looking in detail, and I was scanning all the way away from my wound. Now the wound was right at the base of the palm, in a big person's hand, good 10 centimeters down here. So scanning around the rest of the hand, to my horror, higher up, several centimeters away from where I'd been, I found this other piece of glass. So there was no wound connecting the two of these. There was just a wound here with glass here, which I removed, and there was nothing to see higher up here. Now we can see, well away from the site of the initial wound, there was another piece of retained glass, which I'm going to be honest, at this point in time, I wouldn't have been fully aware of. I was very focused on this wound and this piece of glass, and I got it. And that could have been quite bad. So we got an X-ray to confirm, and you can see there's this large triangular piece of glass higher up. So this has been the only example of a little bit of a whoopsie that I've had during POCUS of foreign bodies, but I think it's just really important for me to pass that on to you guys of the pitfall of, even if there's no connecting wound and the skin's completely intact, clearly this glass, some glass had gone in there and some had gone right up underneath the skin and either broke off to here. And yeah, it could have been really quite bad. So I think I've maybe removed about 10, 11 or 12, something like that, 10, 12 foreign bodies, obviously in the select cases of the children who are old enough for going to be able to tolerate it, with foreign bodies sufficiently superficial, not too deep. And some of them have been rapid and really good and excellent and satisfied. Some of them have been a fiddle and have took about half an hour. I think in one case, I didn't feel confident. I was getting everything out and it was just turning into a bit of a saga. So I had to kind of ask orthopedics to get to whether, that I demonstrated a foreign body. Obviously, X-ray hadn't shown the foreign body in the first place for nearly all of the cases that we get involved with for POCUS. So I'm still making a massive case for utilizing POCUS for foreign bodies, but often it's the removal that can sometimes be a bit of a fiddle. So I would caution people about taking that on, and then at least when we've seen it with POCUS, we can then speak to orthopedics and they might be more keen for us to go ahead, keen to get involved for surgical removal if it's something really, really big. But yeah, I would still say have a good look. I would also just say have a scan around of the surrounding area, because you don't want to do what I did. But it was all fine in the end. Any questions about foreign bodies? Okay. So some abdominal cases now. So I saw a 5-year-old girl who had some loose stools and then she had just a short history of abdominal pain. She wasn't eating. She did have a sort of fairly impressive abdomen in terms of totting up a peds appendicitis score. I was already beginning to score some marks for that. And these are the views that I got. So the general right upper quadrant, left upper quadrant views were fine. I saw the bladder. When I then did a curvilinear view before I've started with a high frequency here, I tend to sort of have a good look at the right lower quadrant and see what it's like. See here, we've maybe got some sluggish loops of bowel. Anyone who's been on the videos that we put up about bowel obstruction will be familiar with some of the appearances. So if you haven't, you can go and have a little look. But I tend to just look over here and see what it looks like. And I was like, okay, that's interesting. What am I going to see with a high frequency probe? So when I did, I saw this really unusual appearance, this really fixed, what looked obviously like a fixed loop of bowel, very, very echogenic around it, thickened walls, fluid filled. But I thought that can't be the appendix. It just doesn't seem to have the signature. I've never seen it that fluid filled. We've got some large bowel gas pattern there, so could connect to cecum and be a little short, but very distended appendix. But I just thought it was too big from any of the ones that I've seen. We're getting, sorry, trying to click that. We're getting on for sort of over 2 centimeters in size, or close to, with very thickened walls. So I knew something was going on. Clearly, the way the child behaved during the scan and the clinical pretest probability made me interested. We did some bloods. We've got an elevated white count and neutrophils, and in this case, a decent CRP. So I made a case to the surgeons that I didn't think I was seeing the appendix, but I thought this was convincing for appendicitis. In this case, it was a standard appendicitis with at that point a degree of perforation. So everything was fairly straightforward for the surgeons. Little bit of supervision with one of our local radiologists sort of afterwards, and they feel that this is probably terminal ileum that's there and fixed with possible, you could say that a fat wrapped appendix could be sitting here below, but I think the pearl that I'm going to get onto after the next abdominal case will just tell you to keep your index of suspicion high for appendicitis or something else, even if you don't see it. So I'll link that in with this next case. So I saw a 13-year-old girl who'd had some abdominal pain, again, quite a short history. She'd obviously just had a Spice Girls tribute band audition that morning by the look of her. And she had some pain whenever I went anywhere near a right leg fossa and was Rovsing's positive. Again, I think bloods might have already been undertaken by one of my colleagues before I scanned, and elevated white count and neutrophils, and again, a bit of a sort of moderate CRP. Obviously, interestingly, the CRP doesn't feature in your pediatric appendicitis score. But again, I had a look. The curvilinear views, right upper quadrant, left upper quadrant, pelvis were fine, but this was all right lower quadrant. So in these two views, it was really unusual. I was again seeing what I thought was fluid-filled, possibly distended loop, possibly collection, some echogenic material floating within, but no obvious peristalsis. We're right over the region where we expect the appendix to sit, so the iliac artery is there. Got probably psoas muscle here, subcutaneous fat above it. But then this appearance in the same region, slightly lower, gave a really, really good impression for possibly a sort of what I'd expect with an emergent appendicitis. So we're obviously seeing some inflammatory fat wrapping here. And again, I couldn't appreciate an appendix, but I was concerned enough. So she had a radiology scan, and they had said that, as you can read it, cecum and terminal ileum look normal. However, appendix was not identified, making it unlikely, but it was early. But didn't really report any of the positive findings that I'd found. So, she was tender, and this is super abnormal, let me tell you. So sometimes you'll get a radiology report, and I try to work super, super closely with them. A lot of them I know well, but they answer really specific questions in a way that maybe as the clinician seeing them and examining them and trying to make sense of POCUS findings, they maybe don't touch upon everything I've found in the past. They're sort of there to obviously assess all of the anatomy and answer the question about appendicitis, but I found sometimes it's a more guarded report. I don't know if anyone's had similar experiences. So this girl eventually went for an MRI, and it showed a posterior medial appendix from the cecum, i.e., well, no, it doesn't say in this report even there, but I'll go to skip to it, a retrocecal appendix. So I've never seen a view like this before. It's quite nice with all this inflammatory fat around it, and then this lovely appendix pouching off there. This is probably why we didn't see it. And yeah, when she went to theatre, retrocecal appendix with a walled-off abscess, that was probably that fat-wrapped area. What was really interesting is when I got a histology. I always follow up the histologies. It was obviously appendicitis, but only 5 millimeters in diameter, which again, for us, for POCUS, we wouldn't really use that as a cutoff for everything. We'd talk about 6 millimeters and above. So yeah, just thought it was really interesting, which in a long-winded way brings me on to the pearl, which is definitely this, and this would be the biggest one I would say to you guys today to remember. If you're beginning to scan abdomens and you've had sufficient training and you're in a position where you're thinking about appendicitis, which is a really great thing to start. It's one of my favorite areas to scan. I would just say this: if your right lower quadrant appearances aren't as expected, even if you don't see the appendix, let me tell you, you're definitely onto something. So always bear that in mind. And this is a really excellent paper which talks about the secondary signs and the value of the predictive value of the secondary signs such as, regional small pockets of fluid, lymph nodes, inflammatory fat wrapping, some signs on Doppler and things like that, even if you're not beginning to see even if you don't definitively see the appendix. Any questions about appendicitis or any of the other cases there? Okay. So yeah, another 14-year-old girl came in with abdominal pain, again, short history, felt like it was right at fossa, was definitely tender, had some bloods done. Bloods were fairly unremarkable. Yeah. And again, this is direct from the notes. So I'd scanned to look for an appendix after one of my colleagues requested. And this is what I saw, which is definitely something we don't see that commonly for abdominal cases, that are straightforward. I saw a decent amount of free fluid, right and left. I was like, wow, this is impressive. So tip of spleen, not a really good view of subdiaphragmatic for the spleen on this particular clip, sorry, which is exactly where where the free fluid should be in the left upper quadrant. So that's really naughty of me, but we can see here on the right, we've got it Morrison's pouch as well. So then I had a look lower down and I found some really interesting stuff, which I wasn't too sure exactly what it was. But again, what I thought was a really decent amount of free fluid. Hopefully you guys on the call agree with that, for those who are doing either fast scans or scanning abdomens for other reasons. And yeah, so I went and asked for a scan around the corner, and they looked at the uterus and ovaries, which felt to be fairly unremarkable. And what was documented there is a minimal amount of free fluid. So I was like, okay, what do you do with that? So I started having a look around the kind of physiological amounts of free fluid that are there, and there's not a lot in the literature if you look about it in terms of ultrasonographic amounts of physiological free fluid in a female. But I was concerned, and outcome wasn't the most satisfying, to be honest, because we kept her in the department for most of the day. I discussed findings with the surgeons and asked if they were interested, and they weren't particularly, pardon me, with the bloods. And she completely settled down and went back to normal after about 6 hours. So we sent her home, and the whole thing just left me more confused than anything else, really. So especially with the right upper and left, right and left upper quadrant appearances, given that you can have a significant abdominal trauma and not see free fluid from trauma. So that was interesting. So pitfall would be, don't be fooled by free fluid, but definitely don't ignore it. Okay, now we got some cases on neck lumps. So I saw a 2-month-old with a neck lump. There'd been some vomiting and possibly some loose stool, according to the team, the junior doctor who'd taken the history, and parents effectively just noticed a lump in sort of mid-anterior part of the neck. Background was unremarkable. It was actually a member of staff from our PICU's child. And yeah, on examination, there was a firm swelling, sort of submandibular, upper jugular, that kind of area. So my thoughts on these is, clinical examination alone can only add so much here. So bearing in mind, this was one of the latter things that I learned to scan and sort of developed a bit of comfort with. All of these next 3 cases are really interesting, different neck lumps that have kind of really shocked and surprised me that what is there. But I think your clinical examination can only take you so far. So I think it is tricky to not make a case for learning to develop some skills in POCUS for that. So this is what I'd written directly in the notes. So 3 by 3. So already that's a really big size. That's way bigger than we normally see in normals, but also much bigger than you'd see in simple reactive lymph nodes for your day-to-day lymphadenitis. Solid structure is spherical. Okay, so spherical is not good. If you see spherical, it is really not what you want to see. I'll talk a bit about lymph nodes as I go, but we'll just stick with this case first of all. Heterogeneous, not good either, and cystic areas usually not good. So there were some surrounding lymph nodes that I was happy with, normal size, normal architecture. I made it sound like this was going to be malignancy there, didn't the way I was talking? Because a lot of the features can overlap. But in this case, I was happy that this was basically an abscess. All right, features suggestive of early abscess / lymphadenitis. So these are the appearances. Now, a perfectly round node like this, you do not see. Lymph nodes are normally bean shaped. All right, did a paper on this that you can have a look up. I think one of the cases part of this is in that paper, but should have a long versus short axis ratio of 2 to 1-ish, at least kind of 1.5, 2 to 1, so twice as long as short. When you see it circular like this, it's always something really unusual. Also, this is very heterogeneous, so the internal architecture of it's very unusual. We've got some little bright areas, but we've got these funny little cystic pockets that you don't normally see. You can see these more normal looking lymph nodes. I appreciate you only seeing them in brief cross section, but these would all be, sorry, I'll point to one, maybe pause it. You know, this, when you see it in its proper full axis, would look more like a bean shape, and the ones up and around it, sorry, I can't get a great view on these, but these kinds of ones would look much more, you know, 2 to 1, like not like more like an oval or a bean. So I wasn't really happy with this, and I thought, yeah, this is definitely going to become an abscess if we don't treat it. Plus, it's a small baby; it's very large in size, so it was a bit strange. We did some bloods, and there was a elevated white count, elevated platelets. CRP was, you know, it's high for a small baby, but might not impress everybody who looks at that. So they got a formal radiological scan, and again, you can clearly see these really cystic areas, multiple lymph nodes. Largest is that by that. Interestingly, they take a slightly different measurement of what I had on my screen, so that's interesting. Cystic areas. So they've described this as lymphadenitis. So we started baby on IVs. 3 days later, this was not behaving just like your average lymphadenitis, and the following scans will show you that. So this was a level 2 lymph node that's sort of like upper jugular, central necrosis. Well, we don't normally see that. Complexity with debris, we don't see that. And reduced echogenic hilum. The echogenic hilum is the nourishing sort of hilum, you know, the anatomy picture of a lymph node, what you're used to seeing. I've got some pictures later on, but I won't skip too far ahead. You know, the vessels and the lymphatic flow gives you that echogenic hilum, which would look very, very bright, or it would be picked up by a Doppler signal. Okay, so this is where I was watching from afar with this child on the ward and reading all of the different day-to-day updates from the ward rounds and the bloods that were done, and the fact that this child was still having fever and not really improving after 2 to 3, 4 days of antibiotics. And I was seeing these scans, and I was not liking what I was reading, because I've got to be honest, I totally disagreed with them. I didn't think that this was representative of stable disease, because stable disease means, you know, simple changes aren't worsening. You know, this central hypoechoic region here is basically forming an abscess, and I was kind of like, I didn't understand in this context what was meant by stable disease. I thought this is a small baby who's still on the ward, still not doing great. This is not behaving like treated lymphadenitis. Anyway, so further down the line, they got a further scan because the child was still not doing very, very well, fever, etc., despite IV antibiotics. And yeah, there's a further area of low hypoechoic echogenicity with liquefaction, and they went for aspiration, and it was an abscess. These are examples of the bloods, and you know what we look for as pediatricians or as neonatologists. You know, you see the change of the white count kind of halving, don't you, commencing an appropriate antibiotic, with inflammatory markers and all the other inflammatory signs going up, going down. You know, you could see from these platelets that was just, for the pediatrician on the ward round, they would not have been happy seeing that, because this is not following the pattern that you expect for a treated something simple like a cellulitis or a lymphadenitis or a synovitis. And I've got to be honest, I just knew from this first image that is going to be an abscess. That is not what lymphadenitis looks like normally day to day, nor is that, and definitely not as that. So it was sort of like I was watching from a distance, not involved anymore, but it was really, it was strange, but it was also an interesting learning point that, you know, everyone can get things right. I certainly can get things wrong. I certainly will, and I think anyone can. you know, any specialist can, any surgeon can, and I guess theoretically any radiologist can as well. This was a different neck lump of a 24-day-old baby who parents had just noticed this firm lump, wasn't there at birth. It was sort of much lower down, getting on towards the sort of lower part of towards the clavicle. Baby was doing entirely well, feeding beautifully. And again, it seemed like in the lower part of the jugular region, there's this firm non-tender mass. So this is what I saw this time. I did a scan because I couldn't add a great deal else just from examination. Play these a few times for you. So here we can hopefully see some vascular structures, maybe see some normal lymph nodes that I was talking to you about. Here's a great example. Stop. That's a perfect example of a lymph node. Yes, see the echogenic hilum, smooth walls, really, really small, about half a centimeter. Sorry, about 1.5 by maybe half, with that. So that's a good example of a lymph node. So this is what I saw. Got vascular flow in and around just from vessels, but no enhancement within. Does anybody have an idea what this might be? Any pediatricians on the call want to put it in the chat or speak up?
Looks like fibromatosis coli.
Yes, spot on. Excellent, good. So this is this sort of anxiety-inducing thing from parents, which is a fairly benign thing for us pediatricians, which is something called fibromatosis coli. I had it on a previous, on my other version of my talk. One sec. I don't want to mess up the whole talk now, but let me just share it on the other thing because I've got a slide on it and this version of the talk didn't update for some reason. One sec. Probably not going to be worth it in the end, but just to show you. Yeah, I'm going to do it from here. One sec. Can everyone see the other screen now?
Yep.
So this is the anatomy of the lymph node and the nourishing hilum coming in. This is the blood flow. This is the 2x1 measurement. And then just to skip, just because I'd added these in this morning for you guys to see, talking about, you know, the knot within the sternomastoid muscle. And what you get in this particular condition is you get this sort of fusiform dilatation of the muscular fibers. So you can really clearly see the muscular fibers running in nicely and being contiguous with this mass. There's no echogenic stuff around it on POCUS in terms of being very, very inflammatory. What you can get within the muscle is some changes, which are quite unusual. I'll stop sharing now. That's all right. Went the long way around doing that tonight. Right, 2 seconds. So yeah, so what you can get within the muscle on POCUS is you can get some regions of mixed echogenicity, and that's because these sort of internal fibroblasts and the things that you get within can form kind of very complex patterns and knots, and yeah, they can be sometimes a bit misleading, but the clue with these ones is that, you know, the child's obviously very well at you're using your POCUS to confirm what you already think it is if you're familiar with this condition, but you can clearly see these fibers of the musculature running deep within and then just dilating out, so you know that it's not really likely to be associated with any other structure such as a lymph node or a malignancy or something else like that. Does that all make sense? But yeah, the people who mentioned it in the chat, its other name is pseudotumor, sternocleidomastoid pseudotumor, isn't it? So parents get quite concerned. I seem to be able to get scans in hours, as someone's mentioned. Really just because I think now they know me and they've known me for a few years and I can, yeah, I think I said on the first call, if anyone was around, I try not to create any work for them. I'd hope I haven't so far, and I normally have really specific questions to ask after having done a scan. So I think it's just all about fostering a good relationship going forward when you learn to do more scanning, and they'll get to know you, and just be a friendly face. Go and ask them if, you know, ask them to teach you some things. I probably just annoyed them enough at first that they've broken them down and they're happy to help out. But yeah, sternocleidomastoid tumor. So that was quite an interesting change from the previous condition, sorry, was a neck lump. But I think you'd be well within your rights to have a little look at these if you've had sufficient training. And you can clearly see from that, this is a muscular swelling. It's nothing to worry about. And you can bring the parents' anxiety from that down to that pretty quick. Right, last case, or maybe second to last, but this is really interesting and very different. So this was a girl who had a neck lump. Again, similar story. The parents were adamant that when she left for nursery, this mass was not there. Unusual, but that is the story you hear a lot. She was totally well. There was no impact on breathing, swallowing, feeding, anything like that. But this is what I saw. Now, this is a big lump. And this, again, is not in the area that, I mean, it could be another example of sternomastoid, I suppose, looking at it with that. But it was not the kind of thing that I didn't really like the look of it either. So her background was totally unremarkable as girl. She examined well, but I noted what I thought was a 5x5 lump. Now, we always overestimate the size of things, don't we? Because we've got this connective tissues in the skin. But when you start scanning, you realize that things aren't as big as what you think. They're kind of maximally 2 centimeters, 2.5, getting on for 3. But this was big, and I was worried. So I did some bloods. Bloods were unremarkable, nothing going on. And these were my appearances. So again, there's so much about this that I don't like. It is very rounded. It is very complex. There are cystic areas. I couldn't make it fit with being within a muscle. I definitely didn't think it was suggestive of a lymph node, just based on it didn't look like a kind of an evolving abscess, because you don't really tend to get so many separate cystic areas. You normally get sort of areas that get bigger after time, like on our other case. And just a lot of things about it wasn't lymph node like. She had that, and I had arranged for her to have a radiology scan, but we also did a chest X-ray to look for a number of things, as you might gather, widened hilum and any other chest lesions themselves. We didn't see anything with that. We got a radius scan, which again showed the same thing: circular, big, internal, increased vascularity. Not a good thing, I'm afraid. And then this was the MRI that we got within 45 minutes of my scan, which, as you can see, is more swelling than baby, unfortunately. So we knew this was not good news, just based on its appearances and size and size. And this was the MRI report. I'll let you have a little read. So, yeah, sinister causes were the front runners from this complex sort of lesion. So, jumping forward a little bit, ENT team were involved, specialist team were involved, oncology team were by this point involved. The child spent one afternoon getting pretty much everything worked up and sorted. And what she had was incredibly rare. She had something which I'd never heard of, called an extraosseous Ewing sarcoma. So Ewing sarcoma itself is not one of the commoner ones. It's less common than osteosarcoma, but that's normally within the bones where you expect it. This was extraosseous, so I think there was only about 10 cases of this worldwide at the time. Might be a little bit more than that, but our patient eventually went on to have chemotherapy, and she was the UK youngest ever recipient of proton beam therapy, and she did well in the immediate term. So neck lump scanning is really interesting. It's obviously something that you're going to be and should be doing maybe towards the end of your time, picking up a probe and scanning for lungs and doing more familiar things. Or at least that's how I did it. But I think we're only ever comparing POCUS to clinical examination alone, or any other bedside day-to-day tools that we can use. We're never going to compare POCUS versus MRI or POCUS versus CT. Yes, we can do a study that answers specific questions comparing the two of those, and that is something that'll take take the body of evidence forward for POCUS in the future, but that's definitely not how I think about it day to day, and that's not how I'd argue it with a colleague. I would say it adds value, it's non-irradiating, it's quick, it can be repeated, but it's always going to be used in conjunction with everything else that's going on. So I would never want this child not to have cross-sectional imaging. This child got all of this so quickly because of this scan and because of that follow-up scan and because of everything else. But I would definitely say the POCUS adds a lot more information than examination by itself. And if in doubt, we can get a more formal scan. And then when we wrote this paper for the POCUS journal that involved this girl's neck lump, I don't have a link to it, but it's called A Rare Cause of Neck Lump, if you want to Google it. They asked me to come up with this sort of algorithm, and this didn't exist in the literature. So I was felt a bit kind of concerned about formulating something with, not being an ENT surgeon, not being a radiologist, but this is sort of based on some of the evidence that we've got out there based on sonographic appearances of neck lumps. And this is kind of an algorithm of what I would use in my head for when I'm concerned versus when I'm not. And I just think it's okay if not everything you see is familiar. You're never going to be scanning someone at most stages of your training for POCUS and sending someone straight home without being certain. I certainly wouldn't if I saw something unusual. I'm happy with neck lumps. I'm happy with lymph nodes. Sorry, happy with lymphadenitis, abscess, skin infection, anything that looks really, really horrible and worrying. In which case, going to do other things for that. And then, I might see something vascular that I'm unhappy with, or something bony or whatever. In that case, that's just an extension of my clinical exam where I'm going to be then undertaking further imaging. So I think if you're going to scan, that's a really good way to go forward in doing it. A few questions in the chat. For neck lumps, it's always superficial, even probably in an adult. So it's your high frequency or your ultra high frequency probe, giving you a good spatial resolution within a depth of 3 to 4, 5 centimeters maximal. So always the high frequency. And then maximal size for normal lymph nodes. Yeah, there is some bits in the literature, Nigel, about that, about, anything above 2 centimeters or more, we know begins to arouse suspicion. Again, there's probably a bit of paucity of literature for POCUS on this. I mean, there are 20, 30 papers out there, but it's maybe not as well established about what we're seeing day to day for normal children, for well children, or children who come and go, as opposed to big high level ENT oncology kind of patients. But yeah, the larger the more worrying. Above 2.5 centimeters is a worry because you don't commonly see it. Scanning normal lymph nodes, they're nearly always under about a centimeter. But remember that long to short axis ratio should normally be bean shaped, should be very uniform. They should have a maintained echogenic hilum. They should have smooth walls. They should be regular. There shouldn't be cystic change. There shouldn't be enhanced vasculature. If I was to work through all of that and be fairly happy, if it's a lymph node that I'm seeing and it is slightly enlarged, then I'm happy that I'm calling that a reactive lymph node or a potentially an early lymphadenitis. Lymphadenitis is not really well defined in the literature, actually. If you look it up anywhere, including non-POCUS or non-radiology things, if you look anywhere in an ENT text or article, it's really not well defined exactly what it is, but obviously everyone knows that it's a cluster of lymph nodes. So you can see between 5 and 30 lymph nodes all clustered together. And that's just what we mean by lymphadenitis. We mean multiple reactive lymph nodes. So yeah, so neck lumps is one that can take time to master, but I think it's really good to just begin to start having a look. If you see what you think is a pseudotumor, sternocleidomastoid mass, you can probably at least confirm that it's part of the musculature. And if you need to, check it with your radiologist, or check it with me or something like that. But hopefully, you're at least having your eyes open to different means of scans based on today's talk that you can begin to take forward and practice. Just going to end with my usual final slide. Any questions at all from anyone about any of the cases we've had today? Happy to answer them. It's gone too, but happy to. No problem, Louise, thanks. If anyone wants to get in touch with any questions, feel free. If anyone wants any topics that they'd like us to present upon, feel free. Hopefully you get a break from me soon, because we can get the testicular talk back in the new year. But then also we can get, we've got one of my colleagues, hopefully can all make the December session Nigel's already put the link in earlier, I think. So one of my colleagues from the USA, Matt, who's really, really experienced, is going to be giving a talk on POCUS guided regional anesthesia. So, you know, we all know a bit about femoral nerve block, but hopefully he can teach us all something on different types of blocks that we can be using. I've seen a variation on this talk in the past with the USA group, and it was excellent. So hope to see you all there for some Christmas fun. Thanks for attending. It blows us away that so many of you guys give your time. We've had like 600 people sign up on the mailing list, so we're blown away, and thanks so much. And Nigel's got a short survey, just mainly asking you guys what you'd like to see, you know, and topics to talk on. So it only takes probably 1 or 2 minutes. So if you get a chance to fill it in, great. And have a great day, everyone. Cheers.